how do we make that simple? So for them, primary care, $0. They can understand that. Even someone who's not fully healthcare literate understands zero.
Yes.
To me, you go back to that value. One of the coolest things that we see in a few of our, not all, is when both the member amount they paid and the amount the plan paid starts to go down.
Thanks for tuning in to the Self-Funded with Spencer podcast. Let's go make healthcare better together. All right, gentlemen, let's introduce ourselves real quick. Blake, you've obviously been on before. Riley, we're going to have you on in a separate episode here in a minute. But I'm here with Riley Dearing of Hotchkiss and Blake Allison of EHN. Welcome, guys. Thanks for sitting down. I want to, real quick, before we get each one of your brief bios, why are we here? What are we going to cover today? Because I think this is going to be interesting, a little technical, but fun. So what would you define this episode's theme to be? Riley, I'll go to you.
Yeah, so EHN is a very strategic partner of Hotchkiss. And so we're going to dig in a little bit to EHN, their value prop to our clients, and then some exciting news that we have coming for West Texas.
Ooh, I get to do some reveal of exciting public announcement of news. Blake, and then add some color to that. Like what is EHN, and then Riley, I'll go back to you for bio, and Blake to you for bio as well.
Yeah, so EHN, our Employers Health Network, we're a high-performance network company focused on partnerships between what we think are high-value health systems and providers and self-funded employers. And so we've had a couple-year relationship now with Hotchkiss, really focused on trying to bring their clients forward into the new opportunities and how we bring our provider partnerships and networks to help them save money. We believe improve quality. And so we've been working on that for the last couple of years. And so they've been a great partner, one of our most active consulting partners by far, and really bringing a lot of things from a client perspective, but also challenging us on ways to think about things differently and some different structures. So we're excited about that.
All right. I like it, man. And I'll say for those of you that are listening to this episode right now, Blake you've been on before. It's probably about a year or so ago now. So if anybody wants to really dig into EHN specifically, they can go back and listen to your episode, and I'd encourage you to do so. Thank you. So Riley, real quick, who are you, just in case anybody's not familiar with your work?
Yeah, so Riley Dearing, and I'm the regional leader for Hotchkiss Insurance on the EB division. I work alongside Chris Hamilton, who runs our employee benefits division. And so Hotchkiss Insurance is independent agency across Texas, Dallas, Austin, San Antonio, Houston, Lubbock. And we pride ourselves in taking a little different approach to insurance than the most. So we view it as an insurance policy as a tool, but not the whole strategy. Like there's a strategy, and we're going to utilize insurance to help manage our risk, but that's not the only piece of the equation.
Sure, and I would say real quick, just commentary on that. Like you think about how we would delineate broker and consultant, right? A broker, in our minds, at least at Pareto, and maybe you share that sentiment, is broker shops insurance, right? And the solution is the insurance and the rates that accompany that. What you're talking about is a strategy that undergirds the insurance as a backstop for the strategy. Is that fair to say?
Yes. It's just a way, a mentality and the way you think about how you're going to accomplish your job for your client. So no, we're not going to sit back and just blast the market and shop insurance like it's a home and auto quote. We really get on the side of the table with our client, dig in, and become a part of their organization and helping them map out the next 5 to 10 years. We don't want to think in a 12-month cycle. It's more long-term.
Yeah. And I would say not to sort of diminish the value of the insurance piece, because it's really in value, especially when we talk in the world of stop loss or captives. It's a crucial component, but it's not the strategy. Yeah. It's the enablement of the strategy. So Blake, what about you? Let's get your kind of 2-minute bio as well, if you don't mind.
Yeah, appreciate it. So I joined EHN in 2020, initially working on new market expansion and health system partnerships. So EHN went through a process of saying we want to adjust our focus a little bit from the employer side to building relationships with providers in markets and then going to the self-funded market in that region. So I joined about the time we were launching kind of that approach. And so was in charge of getting out and building relationships with health systems. I joined EHN from the provider side. I'd spent my entire career up to that point working for health systems and specifically more accountable care organizations and clinically integrated networks, and joined EHN to try to marry the idea of ACOs and CINs going to the market more at scale. So did that, and then in 21, our founder and CEO much deserved retirement, and so became CEO in 21, and have been doing that since, and had the privilege of now we're up to a fairly medium-sized company, growing slowly but surely, and it's been great.
Having spent years working alongside healthcare leaders, brokers, and employers, I know how overwhelming healthcare can feel for our customers. We've all been there. Those renewal conversations that never seem to get easier. Rising pharmacy costs and medical costs, and no real transparency into where healthcare dollars are going. That's why I'm excited about Nomi Health. They're not just fixing the old system. They've rebuilt self-funded benefits from the ground up. With Nomi's network, you can offer something truly different. No copays, no deductibles, zero out-of-pocket costs when members see a provider. It's the kind of benefit that makes everyone ask, why hasn't healthcare always worked this way? Ready to bring your clients something different? Visit nomihealth.com and see how Nomi is rebuilding healthcare, one employer and one community at a time. Well, and so we used a couple of terms before. A clinically integrated network is one of them. But what would you define for me a high performance network? Like describe what that actually means.
Yeah, for us, it's really to that value equation. So we do care about the cost of healthcare, and that's to the big C. Mm-hmm. So in our networks, because the way we structure them, the price of the thing needs to come down. And so if you paid $100 for that before, if you come on to EHN, you should pay a substantial decrease from that. So big C, cost. And then what we do on the high value side is we really do try to align ourselves with providers, health systems, hospitals that are indexed towards value-based care, working on things that are much more geared towards quality. We think that elevates the quality side and the performance. And so we do want that per member per month to be somewhat predictable over time.
Sure.
So we want to reset the baseline, and then we want to minimize your growth over the baseline over time. And so that to us is the high value. So it's now 20% less, and then we're not going to grow at the same clip year over year before because we're with a mechanism that's trying to focus on coordination, quality, better outcomes.
When I think of value, right, value is in the eye of the beholder when we do the transaction in and of itself. Value could be lower cost, but to me, value also includes quality, a quality component of that as well. Is that fair?
I think it has to. I mean, sometimes you have to, even in our world, there's things that people need access to that are very high quality, and you're not always going to get those at the lowest possible price. And I'm not sure you want to.
Sure.
So we try to balance that. I think certain things you should get at a lower price repetitively. Yep. But we should also create a world where you can get access to really, impressive, high-end services that are well done. And, we're going to try to manage the cost the best we can, but you also just need that. And sometimes that's why you have insurance. Yeah. Is those things happen, and so having access to it. So it is a balance. Yeah. But we try to push on both.
Okay. Where did y'all's relationship start, Riley? When did you become aware of EHN?
A couple of years ago.
Is there a funny story here? I see.
No, because it all depends on which perspective. Yeah, it's like I started hearing Riley's name and probably then we now we know.
So we started working together and had groups with each other a couple of years ago, but we heard of each other before that for a year or two through a TPA partner. Said, hey, I want to introduce you to. They didn't have a solution for where my client base was at the time, which was 4 or 5 years ago. My client base has spread beyond just West Texas. I've got clients Dallas, Fort Worth, and all down Central Texas now, which fits with EHN obviously. So it was through a TPA partner.
Okay, and the TPA partner. So HPI, I think we kind of covered that in the sort of prologue or interlude, whatever you want to call that. First part, but the relationship between HPI and EHN. Let's go ahead and at least talk about that for a moment and define that, and then perhaps where you might fit in outside of HPI as well.
Yeah, so HPI, we're a wholly owned subsidiary of Health Plans Inc. or HPI. We operate still as EHN. We're able to operate in the market that way. They've been a great partner. They are our owner. It's nice to have that vertical integration with a TPA when you do network things, because we don't venture into any of the real TPA services. So we're very consistent on wanting to be good at what we do and not try to do things that start to either interfere with or create confusion. So HPI was a partner of ours for a long, long time and had been a partner, made sense. That said, I think they recognize and we recognize that to be successful in the market, not everybody's going to like the same flavor of ice cream. And so we do go through a process that we have developed where we will work with other TPAs, but we work them through what we call an accreditation, where they have to We have to make sure there's strategic and operational alignment. It's not just an agnostic.
When they have to understand what you do. Right?
They do. We're not easy. I think of a TPOs here. We're not always easy to work with because of the structure we have with our provider partners and that pricing. There's rules that come along with that. Most every network has rules, but ours can be a little bit more intense. But it's intended to balance the value for all parties and make sure there's a win-win. So we do have structural things that we need to, take in. And so I think that some TPAs are willing and some less so.
Not so much, yeah. And so Riley, let's get into the why, if you don't mind. Like, why would somebody and an employer want to pursue a high-performance network versus a traditional network they can get access to any day of the week?
Yeah. So when somebody engages Hotchkiss, a larger employer engages Hotchkiss, initially, most of the time it's because we need a second look at our health plan and our strategies and what are we doing. And you and I have talked a lot about the mechanisms or the tiers of a health plan.
Yeah.
Whether you're fully insured, self-funded, partially self-funded, level funded, split funded, whatever it may be, you've got really 4 tiers or mechanisms of your plan. You've got an administrator, you've got a network, you've got a PBM, and you do have stop loss. Even if you're fully insured, you've got stop loss. And when you're able to break those down and understand, okay, we don't have to be bundled with ASO or fully insured. So let's now look at, okay, today you're fully insured and your administrator is this, your network's this, PBM is this, but it's brought to you and here's your rates. When we take that apart and start putting it back together, it's you get to the network piece, okay? And so what makes the most sense? Well, geographically, if they're in an area that EHN has coverage, we're able to educate them on how can we layer them in to provide high quality at a lower cost to your members. And in the end, my mentor in this industry back in 2015 told me the price of your health insurance is going to be 2 things: the price through the door and how many times do you walk through the door. So how healthy is your population?
Yeah.
And when they walk through the doorway of that hospital, what is your plan paying?
Sure.
This conversation and EHN steps in for the price through the door equation. And how are we impacting that when they walk through the door to a high quality provider?
Yeah. Well, and so what if I'm an employer hearing this and I'm intrigued at least by the idea, what might I be giving up if I use a traditional network that they, let's call it an Aetna or a UHC network, something to that effect? I'm self-funded. I feel like I'm doing the right things. I've got an independent TPA that's accessing those networks, but I'm still probably giving up something. So what am I giving up if I still use a traditional network?
Well, it's the facilities. If everybody out there is all in the network, then the facilities don't really have any desire to negotiate any lower rates. And EHN has direct agreements with specific facilities that they have strategically reached out to based on quality, location, outcomes, all of that. So there's a quality matrix to it and a pricing mechanism to it. And so when you're able to layer EHN on that, you're going to get high quality, lower cost, but a broad PPO where every facility and every doctor's in, they're not able to negotiate those rates down because you're not steering traffic to a specific facility. With a network like EHN, we're going to be telling that facility, we're coming to you.
Yeah.
You're our partner in this area. You're it. And we're going to incentivize through plan design to come to you. And for that, here's what we would like in as far as rates go.
Yeah. And then for you, Blake, the role that you play is obviously identifying those facilities and then negotiating the terms of that agreement, right? And then make it scalable as well. So talk to me about that process.
Yeah, so we do network development, network management are the 2 nice terms they talk about. So we do all the development up front. So we create a fully adequate network. And what I mean by that is if you put us in on a fully insured plan and you tested us against departments of insurance, our network would meet the adequacy standards, meaning the members have access within a certain geography to every specialty type they would in our geography. So one thing I always want to separate is we don't just do a hospital contract. We truly build a pediatric to post-acute, every
Really?
stop along the road network where a member can reasonably, in that benefit design, even though there might be a trade-off, can say, okay, I understand that at this benefit structure with this network, I can get access to every type of care I would ever need.
Okay.
And I mean, even to the moments of, like, we have facilities that will take your organs out and put new ones in if you need a transplant, level 1 trauma, cancer. So we build that out. So that's the development side. And then in that, you're correct, we have all that paperwork. All those contracts live with EHN. They exist in our repricing environment. And then we do all the network management around repricing the claims, the directory to make sure members have nowhere to go. We make sure that the network, if it has a gap, we fill the gap on an ongoing basis, and that we're managing that network across the population.
ClaimDoc is a medical claim auditing and member advocacy company. We provide fiduciary services to employer-sponsored benefit plans, and allowing them to create an environment where we ensure that the benefit plans are being charged in a fair and reasonable basis.
My business is basically people, and it become a real simple transition. We thought it was going to be far more complex. I've saved, we'll say, hundreds of thousands of dollars. I could not say enough about ClaimDoc.
You said reasonable access to what would be defined as reasonable then? Because to what Riley was saying earlier, a boilerplate network's diluted because everybody's in network, right? But
Yeah.
So what is reasonable access to those?
I mean, we do it by, you should be able to, in a metro, within a few miles, get to whatever type of provider. It just means that the one that might be right next door to you may not be the one. So you might have to go another mile versus that, but you shouldn't have to go 25 miles.
I see.
In fact, our primary care, we tighten that up. We know you kind of lever it, but we're very tight on primary care. We should be within certain, less than 5 miles, multiple providers available. So you may not have the one right closest to you, but you're going to have one within.
You may not have
miles.
your current doctor.
You may not, and that's where I think that's the disruptive part of it. Every one of these solutions has trade-offs.
Sure.
That's ours, right? Is you may not have the provider you did at the same benefit. The thing that Hotchkiss is really good at is they say, we're not taking that away from you. It just means that if you're willing, there's an incentive to go here and it's readily available.
Yeah.
If you really want to stay with your, special, we get that, stay. But if you're willing to make a change, make a change. And so that's a big piece of, what we're trying to create. But we wanted the member, and part of that goes back to that utilization and cost, right, makes PMPM. We also wanted to make sure that if a member entered, there was an incentive to stay in that care plan.
Yeah.
So the primary care knows those, because we usually have put people together that are in this enterprise together. So either they do value-based contracts together, they work, whatever the case may be. The primary care have a muscle memory of admitting or referring to those specialists.
Yeah.
Not to those, but to these. And so we want you to come across that journey. It also keeps air traffic control. We know what's happening when you leave and go to the other health system, we've lost you. And now we've created fragmentation and all those issues. So we also want to make sure the member can get all that care and stay in their diagnosis and stay in that journey within a network of providers who work together.
Yeah.
And we think that'll help minimize.
Well, I was going to ask a follow-up, but I feel like you wanted to comment here for a moment, so let me give you some air there.
Yeah, the HMO, you got to go here, you have to do this.
Yeah.
So if the plan is built appropriately, which really comes up to the consultant. This isn't really an EHN deal. It's not an EHN deal. It's a consultant. It comes to the consultant and understanding how to utilize EHN as a tool or a mechanism of the plan, but also layering in other mechanisms, networks, whatever it may be, so that we don't have a huge disruption in access to facilities.
Yep.
So HMOs get a bad rap because it's like, well, I've got to have a gatekeeper, and then I can only go to this one facility, and I can't go see this doctor. And we really take an approach where we eliminate the HMO, the negatives of an HMO, but we do incentivize through plan design to get to the lowest cost, highest quality provider across all of our plans at Hotchkiss. So I wanted to clarify, because we were a little bit of that sounded like, oh, this is an HMO, but it's not. It doesn't have to be, is my point.
Well, sure. No, the choice component is the incentive structure, and the choice is still, it allows the member to be, I would say, actively involved in that process.
A good consumer of the health plan.
That's a great way to put it. And
we make choices every day, right? All of our consumer choices. And so we've always had a hesitancy to do that in healthcare, and I get it. But as we deal with the looming issues, there's got to be these moments of, the high deductible was intended to create one activity and behavior. Maybe it didn't. So now it's this idea that if we're going to, my view is it didn't either. We have to ask you as that consumer, if you're willing, right? There's trade-off, and you make these decisions. And if there's decisions, there's an outcome. If you don't make decisions, there's another outcome. And that's what we're trying to balance and make as the least amount of decisions as possible. That's the network adequacy piece. We want you to have to make the least hard decisions. Healthcare is personal. We get that. But we also know that you do have to make, if you're going to get the value, there has to be a trade-off.
I think it's also important of when is the end user making that decision.
Good point.
Open enrollment, in my opinion, open enrollment isn't when you put down there and say, okay, here's your EHM plan and here's your broad PPO plan and here's your price that's going to come out of your paycheck, which one you go, and you're sitting there going, well, tell me what's going to happen to me throughout the year. I mean, I don't have any idea what's best. So if you're able to have a plan that at the point of service, they make the decision, am I going in door A or am I going in door B? And somebody tell me what the price of that is to me personally. And then can you follow up with a quality matrix that says, if I go in door A, that saves me X amount of dollars, am I entering a high quality facility?
Well, I think the next step in that decision-making process that I strongly feel employees or members should be aware of, it's not just what is my cost today out of pocket. It's what is this going to do to the cost of healthcare that my employer is providing access to over time? And knowing or being aware of that if I make this decision today, it's because my employer believes that's going to lower the cost of healthcare overall for us as a company, which would therefore lead to stability or even potentially lowering my own contributions over time. If I don't make those decisions, at least now I'm aware of why does healthcare keep costing so much, or why does my insurance keep going up? Well, it's because we're making decisions that aren't intentional with no awareness of what it's actually going to cost us as a collective or as a group. And I think that's the second layer of the conversation that I feel employees should be aware of why we're doing this in the first place. At least that's my opinion. I want to add something to what you said, though. I like the fact that you're assisting with sort of the leakage between the point of primary care to referral. The leakage often happens because that referral is being made without real clarity as to why, at least to the member, and therefore we don't know what it's going to cost us on the other side of that. Sounds like you put guardrails in place to ensure they're the right, perhaps, referrals.
It goes back to that's the importance of the benefit design, because we're not going to gatekeep, we're not going to create that. So you use the benefit design as the tool to say you can go in and out, but if you want to stay in your maximum benefit, and if we get you in the right spot, the primary care doctors generally will influence that decision. Different data points, they say if a primary care doctor tells you, Spencer, to go to this specialist, 70% of the time you'll do that without even really checking on that specialist.
Yes.
So there's a power of that referral. But we still let it be a PPO and behavior. So if you go to the primary care and they say you think you should see this physician and you leave and you want to check that out, we'll have others available, or go somewhere else, you can make a decision, but there's going to be a change. We're going to say, this is where your doctor thinks you should go, this is where your best benefit is. Shouldn't that be enough to get you there?
Sure.
But we're not going to restrict you to that point. Although I do think HMOs were like 30 years too early.
30 years too early?
Like if they were there now, you think about what we're doing now, it's kind of back to this concept of and Kaiser's still out there, right, after all those years doing it. But yeah, we definitely want the member to feel like they can do what they need, but understand what each decision
Well, why do you think, just on that subject, if we can stay on it for a second, why do you think HMOs didn't deliver what the promises were? Or at least didn't scale to be the norm?
It's funny because when I first met my wife, she was on an HMO and I was not. And so I got to actually watch this. I'd never been on one personally, so I had to watch it. I think two things. One, it was early. They came out early in this managed care idea. And I don't think there was enough awareness that we had, what problem were we trying to fix? Mm-hmm. We went from kind of broad, do whatever we want, and then here comes managed care, and HMOs came with it. And then, she experienced what you're high rule, high restriction. So you went from this, we kind of do what we want, to ultra rules, time on the clock when the office visit started. Walk in, had to have a referral, and had to have the gatekeeper give you all the referrals. I just think it was too much too fast. Yeah. Had they found a way to, I don't think it was the network, it was micromanaging, the great word, my healthcare decisions quickly, instead of how do I have maybe I should only just go to primary care. and start there. Maybe we just do that. And so I think it just put too much too fast, and I don't think the consumer was ready. And then but I think they fixed the risk and things like that. I think the other part is people just got economy's growing, talent's out there. Offering that was not very attractive as that thing happened, and so I think companies started abandoning them almost as a competitive. Like I can't offer an HMO if my competitor's offering something more broad and willing to fund that. And so do I start to bail on it because I'm losing talent? But I just think it was too much, too fast at a time when I don't think we really thought healthcare was as big of the issue
that it is today in 2025.
Yeah, and we weren't ready to make these
and that brings us to today, Riley. I think I want to go ahead and get into the why now and why are we here, and let's define what you guys are specifically building together in West Texas.
If you rewind time to, in the early 90s, PPOs started to become a thing, right? Mm-hmm. And that was really the beginning of a lot of issues in health insurance. And in 2008, reference-based pricing. I think it was 2008, the very first reference-based pricing plan.
Is that when it was? I actually don't know the date. Is that the date?
I think it was I could be wrong, but I think it was somewhere around 2008. And I actually think it was in the Dallas-Fort Worth area.
ELAB, isn't it?
Yeah, I think it was a Dallas-Fort Worth area in 2008, reference-based, and that kind of became a thing. There was a lot of pushback. Obviously, there's still pushback from facilities, but it's really clients having what I call that damn it moment. Like, I have to do something different. Like this is just becoming too expensive. So the reference base was kind of a solution, but then there's a lot of disruption. There's a lot of negatives that come to that. The PPO is a broken strategy. HMOs we've talked about. High deductible health plans is, the HSA mechanism. That's great because you're allowing the member to put money there, but it's just cost shifting to the members who, in some instances, don't make enough money to pay for a $7,000 deductible, $6,000 deductible.
I would say in many instances.
Yes, in many instances. Yeah. And so, what can we do that's not reference based, and be damned, we're going to tell the facility what we're paying, and then we're going to fight to the death on balance billing. But then this broad access is broken because there's really no sheriff. It's just the old Wild West, and go where you want, and they may do a surgery they don't need to do, whatever it is. We just got to pay for it, and so. Then there was so we're not going to reference base, we're going to have safe harbors. In the reference base world, I'm going to go get a safe harbor. I'm going to find a safe harbor for my members, whether that, what facility that may be. That happened for a while. And so what can we do to create a high quality, low cost, I don't even want to call it a safe partner of our client's health plan, that allows us then to still have a broad aspect of what the member, the end user, is going to experience. Right. And I think, and Blake may say, no, that's not really why, but I think that it's kind of the right time, right place. Reference base was just so much pushback on it. Broad PPO is broken. What's something that's kind of right there in the middle that we can utilize as a tool as consultants to provide a really high quality benefit at a lower cost? And I think it's a function of the last 12 or 15 years of what healthcare has been.
Yeah, no, and I think you said something that I don't want to miss because I think we skipped over it there. We talk about you and your clients are truly our joint clients, but the providers are our partners, and we say that on purpose. But there's an intentionality with our provider partners to do this for the marketplace. Okay. So we're not going in and getting a contract, having it for a while, hope we don't hit it too much that the facility forgot they gave it to us. This is, these health systems and providers saying, we get the issue. We actually understand the issue that you're talking about, but we have to deal with it in a way that's rational, functional, and scalable. And so we're willing to put value in the marketplace. And I mean, they're employers too. They see the same metrics everybody else sees, but they want, Hotchkiss to go bring hundreds of thousands of groups and lives into this, and they want it to do over and over again. And so, and I say they being our provider partners, this is very much their way of trying to put something out in the marketplace to answer some of the call. They agree with you that they don't want more market share with the BUCAs. Nobody, I mean, in what world do they walk around and go, we'd like Blue Cross Blue Shield to be stronger? So they know that's not a path for self-funded that they want. They have to tolerate them in other areas. And, the value to the health systems on the reference-based pricing side is minimal. So they push back against it.
Sure.
So we get it though. We're not immune to the issues. So there's a very much an intentionality that they view this as their way to offer something. They actually get excited. We've had, the client that one of our clients we have together, we didn't start well. We picked up the phone. Riley wasn't in that meeting, but other folks were. The owner of the dealership came. Our provider partner brought reps. We brought reps, and we sat down and said, what isn't going well and how do we fix it? I mean, it took an hour, but that's exactly and we fixed it. That's the crazy part. And it took an hour. Now, you go to Blue Cross and try to do that, or you come in through a very contentious relationship like other solutions and then try to go sit down and solve problems. What's the incentive? And so the providers very much want to do this. And I think that intentionality also means it has longevity. So they're not going to wake up one day and just because X health system gave us some fantastic contract, they're not going to wake up and go, oh, we didn't mean to do that. They're saying, no. How do you bring more to
Well, what you're describing to me, there's a couple things that come to mind. Yeah, one, I was picturing like you see like a music producer that's while a band is playing and they're dialing up this sound and they're tweaking this over here, they're putting it in whatever. I feel like we're in a element of like we're talking about HMOs and reference-based pricing and PPO. We're dialing cost, we're dialing quality, but you're also now bringing the stakeholders all to the table to say what is the agreeable terms for everybody to be happy. Now, compromise will have to be made by all parties, but we're trying to agree on what is the sweet spot where everybody leaves and goes, hey, we're better for this relationship. And that intentionality, I think, is pretty obvious in this discussion right now. But it's not saying we're going to go punish providers and lower it as close to Medicare as possible, where it's more adversarial in nature. This feels more collaborative, at least in my mind.
It tries to be, and it is. And then we try to be, and not every employer wants to talk to our providers. Not every we're always available. But I do think you made the key point there is you have a buyer and a seller. And over time, for all the reasons we all could spend a lot of time on, those two parties got further and further apart. Mm-hmm. And it entered all the middlemen. Mm-hmm. We're a middleman. And so we're very purposeful, though, to say we want to be one that helps still transact that mission of, are you closer to the buyer and is the buyer closer to you? If not, then we're not doing our job. But we have to have some level of middlemen, but we moved them further to the edge and then yelled at each other.
Well, yeah, you're instead of lawyers yelling at each other, you're the mediator in the middle saying, let's come to the table and let's all talk, let's hash this out. Which, again, that's why I love it. It feels like it's more proactive in having everybody have a voice.
We believe so, yeah. And the providers are very vocal. They want to interact with, in fact, even in West Texas, I think our common friend is the provider.
Yeah.
She's talking, the leader there is talking to Riley, talking to me. We're helping them put this stuff together. They want to go impact, the West Texas market in a positive way. She's driving that, and we're helping her facilitate that. And so we're in the middle of that right now. The party that's absolutely at the table is the health system and their network, and saying, we get what you're trying to accomplish. Here's, and we're the piping. It's all really EHN tries to be, is how do we make that work at scale? But she's absolutely out there saying, this is our way to impact this marketplace in a positive way, but in a way that we understand. But absolutely, let's go sell more lives. Let's bring more employers over. Let's move the market. Let's be impactful, be disruptive to some of the traditional models, and be disruptive to the disruptive models.
Yeah.
But she's as much driving this as anybody else.
Yeah.
Pareto Health is the largest benefits captive in the United States. With nearly 3,000 captive members, $1.3 billion of stop-loss premium in force, and almost 1 million covered lives, no other benefits captive comes close to Pareto Health's scale. But it's not just about the numbers. Pareto Health is a mission-driven organization, and that mission has two distinct parts. Number one, to make self-insurance simple and more accessible for small to mid-sized employers. And number two, to arm them with the most powerful cost management tools on the market. So if you're an employer frustrated with your healthcare outcomes, or you're a benefits consultant looking for an alternative to the status quo, it's time to consider Pareto Health. Pareto Health, where employers come to do self-insurance right, to do it easily, and to do it at scale.
And what's for you specifically, Riley, and for your clients? So you're the consultant in this equation, right? So you're looking at this as a solution you can provide for clients and prospects specifically in West Texas. So give me some of the purpose behind or motivation behind kind of expanding this partnership and identifying a provider that can help you do so with EHN.
Yeah. So it's back to the how can we provide a better benefit to people that is not a disruptive model, whether it be reference-based, HMO, whatever it may be. What can we provide as a benefit that is not as disruptive, but it has a high quality at a lower cost? And in West Texas, there's facilities out there, whether it be in Amarillo, Lubbock, Midland, Odessa, that will do direct agreements or work alongside certain health plans or certain TPAs. But is there a solution like we've had for our clients in Dallas, Houston, San Antonio, at a facility such as Covenant, which is the facility that we're talking about? And so yes and no, there has and there hasn't, but I'm really excited because of the success that the health plans that we've got with our clients in Dallas, Fort Worth, Houston, San Antonio have had with EHN as one of their mechanisms of their health plan. That coming to West Texas and Covenant being that partner of EHN is extremely exciting.
When I don't know that market well, so you mentioned them by name, Covenant. It sounds to me like they're very important in that geography from a care delivery side.
I would, I think most hubs or major communities have the 900-pound gorilla in town. That like they're the one that the people in the community want to go to. Covenant would be that in Lubbock and West Texas.
Okay.
Yeah, we approached them. Just to give you some of the way we take this a little bit maybe too seriously on our times at times. We approached them for the first time in 2021.
Okay.
And we just got our deal inked like 3 months ago. But we were not, and that's a good and bad thing. Part of that was timing. Part of that's understanding the strategy. But it goes to 2 points. One, it needs to make sense for them. And number two, we're very specific and purposeful that just having access, if we're going to live to our mission and deliver, just having access to anybody who's willing to do a deal, not always the best outcome. And we approached them. Didn't make sense at the time. It's great. We agreed to part ways as friends. Fast forward, market dynamics change, maybe some leadership don't know. We never went into that market because we weren't going to go without them. And so they came back around and said, I think they see a different future. But, that's not great for a company to sit on the sideline for 4 years. There's a bad story in there, but it's also that we're very, and that's not, maybe it's unique to EHN, I don't know, but we're rather not go than go without the person that and the relationship and the strategy that's actually going to deliver the result, because otherwise we're just a contracting company.
Yeah.
And there's a lot of those, and you don't need to deal with us or me or our rules just to go get a piece of paper. But if you're going to deliver the value, then you want the right players in the market. I think without a doubt, and he knows it better. I've not been in Lubbock in a long time, but we know it from the state. That is the partner you want in that marketplace, and we're excited that they're willing to.
Interestingly enough, just
go ahead. Please.
So they're and Blake and I've known each other, worked with each other in different part of the state, and why we didn't know each. He was working on a deal, and I was actually trying to work with Covenant on a Hotchkiss specific deal, and then when I found out that he was in there 6-7 months ago, I was like, okay, that's his job, that's what he does. Yeah. And that's fabulous because we're already partnered with EHN and other markets. So I bowed out and told the folks at Covenant, hey, you get a deal with him, and then I know how to make it. I know how to make EHN work for the end user and the clients. You guys do what you need to do, and then once it's the ink's dry, let's talk.
Well, I'm going to stay there. There's another question I want to ask, but I want to stay there because I think that's relevant to what we're talking about. The repeatability and scalability of this, right? Because there's consultants that will go to a specific hospital system and they'll negotiate a direct contract that's kind of a one-off contract, and it's specific to them in that location, but it's not turnkey to then turn around and go do it elsewhere as well. And so I think what I'm hearing is you add to the equation, there's a repeatability component to it. It doesn't mean every single agreement is boilerplate.
Correct.
But you have the ability to enter into the system and say, here's what we do and here's how we price it. Let's talk about applying that to you. Is that correct? Okay.
Exactly correct. Yeah, the environment created a muscle memory and a revenue cycle process, and a process that works a certain way. And one of the things when we first started going forward, we were challenged, and we've been challenged on all fronts, but we said if we're going to play, we've got to make it where it's scalable for us, for the health system, and really, frankly, for even if like only one consultant came forward and said, I'm going to bring all your business, but I might have 5 TPAs across my 100 groups. Like, it's got to work for as much of the market as possible. And what the good news is, we recognize up front, they have built processes, the health systems, to deal with networks. If we can dock into that same process, once we do it once, we can do it 1,000 times.
Yep.
And it doesn't matter what the size, as long as we tell them it's an EHN group, that's all they need to know. And that was just, I think we underplayed that importance. And then we made some changes even in the middle of that, where the health system said, if you can make this tweak, we could scale even more. And so we've done some things it's more of a change we made with how we approach the TPAs, but it made life better over here. And so, some of those things, when you have 40, 50, depending on how you want to think about it, years of muscle memory, to try to just break that and then be shocked when it doesn't go perfect is a little bit, head scratching for me. And we're dealing with, $10 billion organizations, and you're bringing them initially 1,000 lives. Those two things are, if you don't have something built right, that is a recipe for a complete disaster. And we did. We went wrong initially. That was kind of the experience. Some things weren't perfect. We ran into those issues. Sometimes you have to, keep running into the wall before you realize it's really stone. And we said, oh gosh, how do we fix that? And then we tweaked, and then you say, okay, I need you to do what you do. We'll do what we do, and we'll come into that same process. And that, I think, also helped them as the providers also think about the market a little different, to say, well, now that we're like this, you can be more aggressive, for lack of a better word. We can bring more opportunities because we're not going to have as much of everything's a one-off.
Yep. You
can bring us faster opportunities. And so it's been good. I mean, it's a learning. I mean, we think about Covenant. I mean, Covenant is a multi-billion-dollar organization. They deal with hundreds and thousands of millions of patients every day across 20 different payer sources. They're dealing with the feds. They're dealing with Buca, and then you come walking in and go, I want to do something with like my 1,000 lives. And then there's the shock when it's like, we have no idea how to deal with that.
Bless your heart.
Yeah, they're like, you know what? How about you just go back onto that? And so. And then even if you get it, we've seen a lot of them where they start doing it and it doesn't go right because the front desk person forget that's a direct contract. They bill wrong, collect wrong, on we go. So, that scalability is just an ongoing challenge of ours. We get challenged by the consultants in the groups, and we get a lot of challenge from our health systems on, can we make this tweak? But it's an important part to success.
Well, now I want to come back to that in a moment, which is beyond the scalability and repeatability in pockets of the country. I want to come back to how do we then replicate this nationally over time? The one thing I want to ask both of you is the why for the provider. Why would a system want to engage with you? What is the perceived benefit that they're deriving out of a relationship with an EHN? I'll go to you first, Riley, but I want both of y'all's commentary on that.
Well, I mean, if you're in a market that maybe just has one or two systems or 2 or 3 systems, they're looking for traffic. Yeah. They're looking for the folks to say, hey, that's my hospital. That's my network of doctors. That's who I'm going to, as far as the end user. And so this is, and Blake, said something along the same line about Covenant is they're looking at this about the community. What can they do for the community? What can they bring the community? And so it needs to be a partner that understands that, has high quality. And so, well,
I mean, I feel like hospitals today have a little bit of a PR problem. It seems like they get demonized quite a bit in the public eye.
A lot.
Sometimes for good reason with some of the price gouging that we perceive, at least, that they're putting into the marketplace. And so this is an opportunity to lean into that local community and say, we hear you, here's what we're going to do instead. And I actually like that a lot because it's recognition of, especially when we get into bill charges and discounts off bill charges, and it's all sort of fake and smoke and mirrors. And you can't really argue why this payer will reimburse at this rate and this one will reimburse at this rate for the exact same procedure in the same location, the same day. It doesn't make any sense to the end user. So I think this is an acknowledgement of that and say there might be a more transparent way to price these things and price them where it's also repeatable.
And when you start talking about price and impact of an EHN, we actually have a case study on a client in DFW, a large auto dealership, which actually we were on together.
Classic.
Classic Chevrolet. We were on together, and they have a couple thousand employees on their plan, and before they went from the I don't know if you call it archaic, but the reference base approach to EHN. We ran an analysis before that, and the analysis kicked out that we would save them $1 million just on fees.
Wow.
Within the reference base plan that they were on. It was $1 million. That's real money.
Because those fees were a percentage of savings then?
Yes.
Yeah. Okay.
And it's so and then not only that wasn't just a sheet of paper or a spreadsheet we showed them, it's actually what happened. They're now about 3 years in, or 2 or 3 years in, and we talked about this a few weeks ago with Bentley. He was here with us. They've not changed the employer or the employee contribution
in 3 years, or
well, it's actually been 5 years since they went from fully insured to self-funded, but that just continued to exacerbate once they went to EHN.
What do you think about the macroeconomy and inflation in the macroeconomy where everything is more expensive these days? But to be able to hold your rates, even just if you held them to the employees alone would be a win over 5 years. But for the employer to do the same, it's almost unprecedented.
And their claims fund continues to grow.
Yeah.
It's not just like, hey, we're kind of just skimming by and we're paying the bills and the plan's paying the bills.
No, the reserves
are growing in that same time.
Chronic health issues, surprise out-of-network medical bills, inflated medical and prescription drug prices. These issues cost self-insured employers hundreds of millions of dollars every year. Add to this the rising cost of care and potential for waste across the life of a claim, and it's clear that self-insured employers need innovative solutions that lower their health plan spend. At Valence, we've done just that, developed innovation that shifts the current paradigm. A complete and integrated ecosystem solution driven by data, one that manages and simplifies the complexity of medical claim costs. It is through analyzing millions of data points that we enable employers to realize and fuel cost-saving solutions. Valence experts come prepared from day one, targeting the fraction of claims that will drive the majority of health plan costs. That is how our team lives the Valence promise, engaging early and often for smarter, better, faster healthcare.
Yeah, that's amazing. What I want to add, because you're negotiating with these entities, I want your perspective of also what you're hearing from them. They're telling you the value of partnering with you.
Yeah, so I actually used to, initially our hypothesis was that it was like this kind of volume for value and we'll do some of those kind of things. We've been educated that has really little to do with it because if you go to most of our marketplaces, by their metrics, everything's good. Primary offices are full, hospitals are full, they're making some money. Like the market's not telling them there's anything wrong. What we're finding is the reason that we are, able to establish these partnerships is we don't have trusting partners in every place. And that trust is eroding with the large payer, all the issues that we talk about. So they don't have a real, they're distributed through BUCAs. And so a lot of them are starting to say, why I'm one of the few companies that has a distribution strategy that I don't control at all. I give permission to these people I don't trust to go distribute me all over whatever. And then I hope, and hope is not a strategy, that I'm going to get value in return for that. So they turned and said, we need a way. We still get the issue that 65% of the market in most market is self-funded. So those parties over there have no part of this. It's their money. It's our providers. How do we cut across that in an environment with a partner that we can trust and a structure we can trust where we can get clarity of what's happening? And so a lot of it has become truly around, I just need to have a better distribution process, more directly to the consultants and to the employers, that allows them to transact what they need back for me in a way that I can see all the information. I know exactly what's happening, and I can do that over and over again. And then on top of that, I do want to impact my community on my terms. And what I mean by that is a school district approach, one of our provider partners in a different part of this state, Texas, complaining about how much they were going up. And the provider partner said, with that payer you're on, I have a contractually fixed inflator of less than 3%. So if they're quoting you 12, it does not have anything. So if you were getting this much from me last year, you're going to get that plus 3% this year. If they're quoting you this much, you might want to ask them what's in the difference. But it is not strict, because they were saying it's all the health, the same thing we hear. So that gave them this moment of, we're not that problem. And they also recognize, like, I can get value to that employer, but when I go give pricing to these people, I have no idea what makes it to the other side. I don't understand how they quote. I don't know how they're dealing with that. And so this gave them the ability to say, I give a company like EHN this price. We don't take a spread. We do a PEPM, and that price we can turn over and go, when that member walks in and hits the contract, it's going to be that. And so it allowed them to take that value and actually get it to the market without a bunch of markings across that. Even never mind the other issues, and it'll let them say, hey, health system, hey, employer, you want X amount for that? Here it is. Here's how you get it. And so it's shifted from this volume for value, I think, for most of the health systems to, I need to be able to distribute. I don't trust the traditional parties. I need to be able to get my value directly to the employer. And how can I do that? But I need to be able to do it over and over and over again.
Well, you just triggered an idea in my mind. I'm not going to put you on the spot, but I would love, we actually ought to add a health system to the equation on a podcast at some point in the future.
There's a lot.
Hear from them as well. I realize it's difficult to do, and they may not want to be on record sometimes on a podcast, but to the end user, if we can make it happen, I think it would be
we have some that would love to do that. Okay. I mean, I think there's some that are very vocal about they're not trying to buka as its thing. And it's going to exist no matter what. They're very vocal about we want to know we're open for business through a different path. And if you want to come down that path, it's great. We have a lot of paths we're closing that if you try to keep coming in that door, you're going to run into some
what I like is that it's going to allow the market to start dictating if there's demand for it or not, right? And if there is demand, that to me, that signals then I should provide more supply through this channel as well.
Correct.
But you were going to say something. I don't want to interrupt you.
So what Blake just said, the consultant who isn't allowing the TPA or somebody else to shop the stop loss, the consultant understands what he just said and that story, that impacts the stop loss.
Yes.
And what we know about a self-funded health plan, partially self-funded health plan, is it kind of the risk portion of that begins and ends with stop loss. And if you're able to go to that stop loss partner and say, here's what we're doing to help you protect your risk with this mechanism of the health plan, then you're going to get favorable stop loss for the client as well.
Yeah, that's, the thing, I'll give a lot of props to Hotchkiss because they take the time, because we'll get a thing in the door, a prospect, if you want to call it that, and they give us and we know this is the bad. We'll get a question of what's your discount, and we immediately are like, we're like, good. You go do something else. Because we even say we'll concede that your payer partner will tell you the exact same discount that we have, but then we will also they will have to admit to you they have no idea what they won't tell you their discounts at the facilities we work with. So let's just agree to disagree. Hotchkiss says no. I care about the price and what am I paying and how am I paying it, and then I can take that over and transfer it to the other parties to make sure everything gets put together. That group we talked about coming off RBP, I think there was probably a lot of skepticism that we're going to lose something with RBP because impression is, on the stop loss side, there's a value.
You're saying lose something by coming off.
We're going to either have a higher premium, we're going to lose, efficacy of the actual payment of the claims. And I think their ability to walk that over and say, no, we've seen this because we're very transparent in our pricing. We've seen what it looks like. That's all them. And so that group's successful because Hotchkiss pushed, I'm sure.
Well, we're seeing it play. I mean, I won't specify the group, but we're seeing that play out in conversations we're having about some renewals on a group we've had together for a couple of years. And it is materializing in lower stop loss as a result of that. And so I think your thesis is correct, that it should follow suit. I've always told people that stop loss is a function of what the risk profile itself is. And if you drive down the claims, stop loss should, in theory, follow suit, even with leverage trend and other pressures on the underwriting. I want to ask you, though, Blake, is there an efficiency element to the provider from the turnaround of payment or the predictability of payment, less administrative burden, filing insurance, et cetera?
No doubt. They trust the TPA environment a lot more, and they know it gets paid faster, and they know how it works. And so the fact that we work with generally independent or TPAs, absolutely. The next curve we have with them is they're very interested in finding a way to systemically get the member out of the payment side. This is where Hotchkiss is a huge win for them. It goes back to scale. We're trying to figure out how to do this a lot, but they're very vocal that if you can somehow, like if Hotchkiss could go to the market and say, everything you do with us, if it's EHN, it's going to be $0 out of your pocket as a member to go in. They've got more money to give in that because
they're not chasing money.
They're not chasing.
Yeah,
well, they don't love that. That's when you end up in the news, right? You had to put the person that was the poor scenario to collections because of whatever reason. Never mind, they were on a $10,000 deductible. There's no joy for them on chasing, Blake Allison for his payment, but they have a process they have to follow to get payment.
Yeah.
Your plan said you owe us all that, and so they're really big on the next level of efficiency. If we can get the member out of it, there's additional value we can bring to the marketplace. And that value meaning price that we can give. And so we're trying to figure out how to marry up a systemic element of that. So if you do this, then you get.
Well, how does, pardon my ignorance here, but the adjudication process, if the member does choose to go within the narrower network and there's a waiving it out of pocket, what is the adjudication process to ensure that member isn't billed anything? Or can you tell me how that works?
Yeah, it goes back to the TPA setup. Okay, because they'll set up benefit on the TPA. So when they call in to verify benefits, the TPA is going to go, you're at Covenant. Member owes nothing.
Yeah.
And they'll very great got it. I won't ask for
and
payment.
So they don't collect.
And the member comes in, shows the card.
I bet the epiphany that happens with that member the first time to go, wait, I don't owe you anything? Or it's almost too good to be true, I would suspect it feels like.
I mean,
you probably hear some of that.
Yeah, so that kind of plan design I've actually been using for multiple years, 7 or 8 years, sometimes we're just layering in a vendor or two saying, hey, if you'll reach out to this surgery vendor or if you'll reach out to this, cancer vendor, you'll pay $0. So, that's where you're really bringing the value to the community. Having a consultant that understands how to build that, put it together, partner it with the right administrator, partner it with the right PBM, partner it with the right stop loss, adding in the vendors that it takes to put that health plan together and make it run the right way and efficiently. But you're really getting to hey, we're offering a benefit to the people in the community with that plan design.
Yep.
And then I think getting the seller to recognize the value of it and come further. That's our role, is to pull that further and say, okay, if you're at X percent or X price now, if your risk of collection is going to go down to $0 on the member side, they basically are saying that I actually build that into my pricing, that I'm going to not get paid on a certain bucket.
Yeah.
And with Buka, I pay in a whole lot of stuff I'm going to get denied. Right? That's why the rate is so high with them. Is part of it is we know we're going to get haggled over all those claims, so we got to get here to get here. Well, they're saying if I can do that, I'll go further. And then I agree. The impact to, and I think about, what really is the benefit. I mean, what really is the employee base? One of our clients is Whole Foods, and Whole Foods gets a ton of, oh my gosh, it's this, the guy that founded it's a super, really bright guy, wrote a bunch of books. You get down into what we do, it's a $10 an hour person putting salad on a shelf. And you're asking them to go navigate, and that's en masse. How do we make that simple? So for them, primary care, $0. They can understand that. Even someone who's not fully healthcare literate understands zero.
Yes.
And so our health systems are willing to go in. And I think those are the things though we can do over time. And we're not having to go back and have to reset things. The health systems trust us to bring that. They know the consultants can push it, but it allows them to do it. And to me, you go back to that value. One of the coolest things that we see in a few of our, not all, is when both the member amount they paid and the amount the plan paid starts to go down.
Yes.
Because we can make the plan paid go down by putting the member at risk for it, right? And if we can make both go down, then to your point, we're making the members happier. I think you're starting to, those trade-offs start to become less challenging for them when you say, oh gosh, I'm going to go here and have nothing.
Well, to me, this begs a pretty obvious question, is why is this not the norm? Why is this not what most people view as the insurance plan they're being provided by their employer? Why is this not more normal? What are the headwinds that we're going to be up against to turn this into being a more common thing?
I've got a selfish answer. If you want me to.
Please. Yeah.
So I think it's consultant driven, in my opinion. Does your consultant understand these kind of strategies and mechanisms are available in the market, and do they know how to implement them and make them work?
Yeah.
I think that is where it begins and ends.
Yep.
When I got into this industry, we were talking about this before the podcast today. When I got into this industry, I actually started working for a TPA. And then at that TPA, when a consultant came to us, or we went to a consultant or a broker or agent, however you want to define them, we would shop the stop loss, the PBM, the network, and we would do all of that. And as the TPA would bring it to them and say, okay, here's what we have. As a consultant now in 2025, I utilize the TPA for network access in some instances, but it's really administer the plan, and I go put the stop loss in place. I negotiate the stop loss with the consultant. I help the client select what PBM is the best PBM, and we put the plan together in such a way that impacts them and their member, the employer, the plan, the employees. And so, I think it's a understanding the market, the geographical locations of the members, and where do we need access, and that this is out there and it's consultant driven, just like the consultants have now taken on more than they were doing, 10 years ago.
Yeah.
It's if you're not as a consultant shopping the stop loss, and I'm not talking about, I'm going to send it over here to this, company that's going to blast the market and then they're going to come back. I'm talking about you're talking to the underwriter at the company that is partnering in this risk. If you as a consultant aren't doing that, I think you're doing your client a disfavor. If you're not directly negotiating with the PBM and making sure that those, contracts are renegotiated every 18 months or 20, if you're not that in depth with a health plan, I think you're doing your clients a disservice.
What I'm hearing is, how on Christmas Eve, when you realize this Santa present is something you got to put together, and it's like some assembly required, and then you're going through and you do it, but you do it because you feel it's the right, you're the right thing to do. So that toy is put together on Christmas Day, right? And I don't think anybody's under 7 that's listening to this podcast. I'm not revealing I'm Santa to anybody that doesn't know that. Sorry, but I'm hearing you say that, and it's like you have a lot of assembly. Your job in this equation, you've chosen to lean into the more complex and harder to do, and so your job is to assemble it and to make sure that it's delivered as a prepackaged plan, and there's joy that's derived on the other side of that. I think incentive structures in the past have created an impediment to be willing to do that because it is hard. It is more difficult, and so much more responsibility is now put on your plate as a consultant. You've chosen to do that as a differentiator in the market, and that's one of the reasons why we work well together, and I like what you do. But I think this is also hard. I'm just outside looking in. This is hard to do. So you have to find the right partners that know how to do it. And I think like anything, you have to learn through experience actually doing it first before you even know what you're doing. And so I'm just hearing you guys talk about this, and I could answer the question why. It's because not a lot of people even perhaps have the capacity or even the awareness to be able to do something like this.
Yeah, so my high school coach, one of the things he would always tell us is if you do what you always done, you're going to get what you've always got.
Exactly.
And so the health insurance model is, it's broken, but I do feel like there are a network of folks out there that are paving the path and marching the march to help fix it and make it better. And
well, that's one of the reasons we're doing this podcast is just to like raise awareness of the idea, right? But Blake, I do want to have an opportunity for you to answer that similar question, which is like, what are the headwinds or what's preventing this from being commonplace?
Well, first of all, for the millions of people that are watching this, that are
I think it's about 10 million
that are on their like phone or they're on their speakers to their kids, Santa is real. We're going to be really clear on that. Santa is real. So I wanted to make sure we didn't throw that off and have a bunch of interesting people. But it's a good question because it's one that, frankly, I don't have a real great answer to because we sit around and wonder that. I mean, we thought fix certain things, and we're not the only company. The companies like ours. I mean, there's opportunities to work in other markets. So I think Riley's answer is definitely, part of it. I think, definitely what we've probably learned the most is, and this goes back a little bit maybe to the consultant, but then the employers in general, the feeling is they want as much of the ability to extract the value without actually having to have a real conversation with their members about things that they need to do to make a trade-off. Like if we want to save money, we need to do this. I remember when I was working at a health system, we were going to a tiered plan, made sense, right? Tier 1 was going to be our network. You paid less out of pocket and you went up. And I remember the CEO got up in front of all of us at the meeting and we're like, and just real clear, like, one, this is a benefit. We provide it, but number two, if you all want the cost out of your paycheck to start to not be this, we have to do things a little bit differently. And I just, it seems like there's always a want to be able to say, go wherever you want, do whatever you want, but I need to go extract as much value. And so that's the carve outs and the bundle and this and and it's all these things that are wrapped around this idea that the member can still do whatever they want. And we hope is not that they'll go pick this one. And then we wake up at the end of the year and the engagement rate of that. So I think that there's still this, in addition to the consultant, but even through the companies and the HR leaders, like this feeling that if I take something away, that puts me in a negative light. And, HR executives have horrible, they're tough jobs. And part of it is their biggest metric is satisfaction and turnover. And I think there's this constant feeling that if I pull something back, now I think what Riley's been, you can do things more on an incentive side, but I think the initial reaction is, oh, you're taking something away and I have to take something away from my employees. That's going to make them upset. And the minute they say that, if you don't have the conviction on the consultant side to say, no, here's how we can do that, you're right. We'll just go get you another quote and we'll keep things the way they are. And so I get it. I mean, so we're trying to, and I think then you get into how we structure these things. It's not everything is easy to grab the structures at scale. United has rules, but I think there's that still the feeling that we got to this world coming out of although this is now the most HMOs have been mentioned in all your podcasts. Yeah. We came out of the overreaction. We said, we got to let people have all the choice they want. And so that's been the vernacular, at least for the 20 years I've been working in business. It's always been PPOs are most popular, go where you want. Until I was at this one health system where the CEO got up and educated us on why it was going to change. It's been a free-for-all. And I think pulling that back is a really tough thing for HR to do, which I get. And it depends also on what kind of environment, if you feel like you're at risk for talent, things like that. So we have to give them a little bit of grace. And we say up front, do I think we should have 1 million lives? Of course I do. There's some markets where we have pricing that is a place where it shocks me to this day that we don't have, like in Central Florida, we should have 10,000 lives without even batting an eye. The health system, the structure, it's insane. So there's something missing. I mean, we know we don't. But I also have to give, you have to give grace and go, we're not going to fit everything. And we don't expect to. So if you do high-end technical services and you're fighting for talent, the last thing you want to do is go walk in with some benefit design that feels like you're taking something away.
Yeah, but I think it's the same thing as like you have kids, right? So you have your kids want to eat pizza or drink soda. And if you take that away and say you can't eat that tonight, they're going to have a reaction and get upset. But then you're doing it because you want to put the piece of meat or vegetable in their plate instead, because the long-term benefit to them is far greater than letting them indulge in that moment for the thing that they want. And I think employees need to understand the why that's. I don't view it as being taken away, but their perception is it is being taken away.
It can be.
And so then you have to educate them as to why and what the long-term benefit of that is.
So there's a book called Nudge. Richard Thaler wrote. It's a great great book, and he talks about incentives. If you take something away or their perception of that, you have to take one thing away, you have to give 2 or 3 positives in response to a perception of a removal. And that's always resonated in my head since we read that, because I think that's what we live in, right, every day. So if we're going to have this concept of something went away, I think the $0, that's a positive back. So I took this away, but I gave this. Well, then what else can we do around that? And I don't know that we always do a good job of saying, yeah, it is good for you, and if I'm taking something, I need to give you a couple more positives. What Hotchkiss is doing is I think they're getting over that hurdle by saying we immediately link the perception of loss to the perception of gain by minimizing your out-of-pocket, which is real money. And in today's environment, where I argue with my retired dad about the cost of blueberries, money's real. And I do think that's why I feel like the curve's coming again, is because now that idea of I pay less out when I'm really trying to balance budgets at my house and these things matter, I think some of that positives are going to have a bigger impact than they would 5 years ago.
Yeah, there's a story in the way that we're able to design these health plans with EHN as part of one of the mechanisms. There's a story that is appealing to the HR, the CFO, CEO, all of the C-suite, HR, who is boots on the ground dealing with the members and trying to provide better benefit to them. And so there is an appealing story for everybody really involved when you can sit down and get their attention and say, okay, here's what this is going to look like, and then here's what it's going to feel like to your people, and then we're going to add in this stop loss policy, that's going to really put some barriers up on your risk over the next 3 to 5 years, and we're going to be able to predict out what's this going to look like as far as my overall maximum risk. And then you layer in a solid PVM and you build the plan, and you have a story to tell to really everybody in the organization that says, okay, this does make sense.
Yep. Well, let's zoom out to the vision of the future and kind of end the podcast on that note. Riley, for you, what's the importance, or what do you think the impact of this relationship might have in West Texas, or more broadly in Texas? Like, what do you expect it to grow into over time?
Well, I'm excited to see EHN come to West Texas and Covenant have, their mission, and really what they're after is providing something to the community that is impactful. And excited to see really where that can go in West Texas. They've got, it's not really just Lubbock, they've got facilities all around in rural West Texas that will allow there to be like its own little network within West Texas. And then the nice thing about that is, like, if you've got an employee in West Texas that maybe has a plan design where the preferred provider is Covenant through EHN, and that member happens to be in Dallas for the weekend and something happened, well, God, what we're covered here. We're covered at Houston. We've got you've got coverage. So I'm really excited to see where this is going to go, and to get out in the market and educate employers on how impactful it can be for their companies long term and their people. When it comes down to it, I like to think we're all doing what we're doing for the people, the end user, because if we're not, we're missing we're kind of missing it.
Couldn't agree more.
Yeah.
So putting down for 100,000 lives in West Texas. Perfect.
Yeah.
I like that.
Hey, you got to get your partners to commit to a number, right? What's our goal together?
It's over.
But so, Blake, same question to you. Like, your vision, perhaps not just focusing solely on West Texas, but the vision for the future of EHN in the next couple of years. What do you envision that to be?
Yeah, good. I mean, I will for us. One of the things that is exciting about West Texas is the work we do is very easy in the urban, but in a state like Texas, where you've got 4 or 5 major urban, and then it gets real rural real fast. This is exciting to be able to get into an area that's not always as easy to get into as a Dallas or Houston or an Austin. So we're excited about being able to take the solution to an area that I think a lot of folks, including us, have historically had a hard time getting into. And so that's exciting for us, because I do think at times they can be kind of stuck in the BUCA world, because that's all that's really out there, because everybody focuses on the big markets because there's more opportunity. So excited about that. And then for us, like I mentioned, it's a lot. Our next couple, three, we don't know how many. I don't think we'll build a lot more networks without a lot of prompting because it's hard and it takes time. We're very, very fixated on this. How do we keep it pulling the value in our structure with our providers over to the employers? So it's a refinement for us at this point. How do we keep looking at things that are making employers crazy? How do we look at things that are hitting the risk? And then how can we, help bring some of that shared risk forward through the pricing structure to minimize that? Because to us, 5 years from now, we want to look at these groups and go, man, we did hit that value equation. The PMPM's down, they're performing better, and the quality is as good, if not better, but we've pulled it down. So we're very, very fixated on trying to get more value into the marketplace through our provider partners.
Closing thoughts, Riley? Anything you want to say about summarize the episode or what the folks have heard for the last hour or so? Call to action, whatever you want.
Yeah.
Work with Riley.
Yeah.
Work with
Call Hotchkiss.
Call Hotchkiss. Yeah, I think that's a great way to end it. But gentlemen, I appreciate you both coming on. I actually love the kind of the collaborative, two different voices talking about a similar goal. So this has been enlightening. I mean, you and I have sat down together, but it was enlightening to hear the story again and then some. And Riley, I appreciate you coordinating this as well. It's been great. So thank you.
Thank
both.
you. Thanks, man. Appreciate it very much.